morning. I was asked to talk about training in laparoscopic colorectal surgery, and then the second big question was what to do in Russia. Now, I'm not so sure about the second part, but I can certainly talk a little bit about training and about how training was organised over the recent years in the United Kingdom. When I was little, my father kept telling me a story about the first pilots in Serbia. They were basically officers from the Serbian army that were sent to France, where they were trained by British Royal Air Force to fly planes. It was like in 1913. This was one of them. And the story goes that one of the British officers approached them and asked them, "So can you fly?" And these guys, they had no experience whatsoever. They had hardly ever seen a plane. But his answer was, "I don't know. I never tried." And I think this little difference is what we maybe often think when we want to start laparoscopic colorectal surgery. And certainly at the beginning of the experience, it was a bit like this. It was a bit like hit and miss, trial and error. People just tried and saw, were trying to find out what happened. And this graph here is the first report about the learning curve in laparoscopic colorectal surgery. This was in 1995, and they came to the conclusion that you probably need to do about 11 cases, and then you have reached the top of your learning curve. But this was 1995. In 1995, we also listened to this music, and we were watching these films. And this was your president. This was the Prime Minister, and this was the American president. So what I'm trying to say is, it has been a long time ago, and things have changed. When we look at things now and look back, what actually happened, then we can see that when we really analyze this data, it takes probably about 100 to 150 cases when you do it yourself, and when you just try to learn this type of surgery yourself until you get on top of the learning curve. There's one problem with that, because the way we measure these learning curves is by counting how many complications or how many bad outcomes you have, and how long it takes until you have stable results. And that's a very odd concept when you think about it. Basically what we're doing, we're just counting deaths or mortality or morbidity or whatever you want to take, and that's ethically very challenging to do this, and I think it shouldn't be done. We shouldn't count how many bad outcomes we have until we become proficient. The big question is, how can we reduce this learning curve? How can we bring it down? How can we make it safe? And there are some lessons we can learn from laparoscopic cholecystectomies. You can see this was at the beginning or after the introduction of laparoscopic cholecystectomies. And this was a huge thing. This was a true revolution, because what you can see is that not only all the cholecystectomies were all of a sudden done laparoscopically, but the overall cases were increasing. So the indications for laparoscopic or for cholecystectomies were widened. So this had a huge impact. And we don't really know what happened at that time in the early 90s when it was introduced, but there are some indications, or there's some evidence of what happened. And I think this study is actually very interesting. It has never really been acknowledged properly, but I think this is very interesting, because what they did was they were asking 1,500 American surgeons about their practice for cholecystectomies. And they asked them two simple questions. One question was, did you have formal training in terms of fellowship or in terms of some kind of guided course to learn this procedure, or did you just go on a course and then did it yourself? So, did you have training, yes or no? And the second question was, how many cases did you do until you had your first major complication, which is a bile duct injury? And when you look at this, you can see that those who had no training, their first bile duct injury was very early on in the learning curve. As we all know, if you do this operation long enough, sooner or later it can happen to you. So you can see those who had training, it happened much later in the learning curve. So it took a long time until they hit that particular case where they couldn't manage. But what it basically shows is those who had no training, they had very early on the bile duct injury. And that basically shows that they had this complication simply because they were not trained properly. The situation in the UK or in England around 2006 was completely different to what it is now. The national uptake of laparoscopic colorectal surgery was somewhere around 5%, and it didn't really come up. There were a few centres of excellence that were doing it, but it was not widespread. And there were several reasons to this. One was because there were some early reports back in the 90s about safety, oncological safety, about wound site metastasis, and people were careful. The other thing was that until 2003, you could only do this type of surgery as part of a trial. This was the MRC Classic trial. So you had to register and you had to include all the patients in the trial. And the other problem was it was difficult to learn. So people were just very reluctant to take this on. And then something happened which is very particular for the UK. There is an institution in the United Kingdom which is the National Institute of Clinical Excellence. And this is basically an institute that predicts or that prescribes how clinical practice should be performed. So they write all the guidelines, what you do, how do you treat patients, etc. And they all of a sudden came out with this document, which basically is what they call a technology appraisal, which is a guidance of how you should perform surgery. And what they said is that every patient in England should be offered laparoscopic surgery for colorectal resections. At least they should have the alternative. They should be able to choose if it is suitable. And that caused a big problem, because there is a law in England that if a technological appraisal is coming out like this, it has to be implemented within 3 months. But there was no way that they could implement it in 3 months, because there were no surgeons around who could do this type of surgery. So basically they had to find a way how they can train up very quickly a lot of surgeons. And that was the introduction of the National Training Program. The National Training Program is a government-funded training program, and its aim was very clearly to specifically aim for colorectal surgeons, for senior colorectal surgeons who are already specialists in their field, and train them up laparoscopically in the whole country, so that they had coverage of the whole country for laparoscopic surgery. So they invested a lot of money, and they basically came up with a structure which was led by two people. One was the clinical lead, and another one was the educational lead. There was a steering group. This was a group of experts who were just basically deciding how this program should be run. And they identified 11, later 12 centers of excellence where this training should happen. And each training center had a representative, and each training center representative appointed trainers who were then training the surgeons. So you can see here this was kind of geographically more or less fair, that all the regions of England were covered. And the training program was run in a way that should somehow reflect the increasing competence of the surgeons. So it started with an application process, so everybody who wanted to apply could do that, had to be backed up by their own hospital. It was all for free, so the government paid for this. Then they were all sent on a course. The course was basically either a cadaveric course or a course where they were operating on pigs. And that was just the basic familiarization with all the instruments and how to perform basic steps. And then the core bit, and this was really the novel bit of this training program, was supervised training. So each trainee was allocated to one of the training centers, and they performed a number of cases together with an expert. So Amjad and Jim, they're both national trainers, so basically they're taking delegates through the case from start to end. And there's no fixed number to it, so they don't prescribe you have to do 10 cases or 20 cases. They just go on as long as they think it is necessary until they can be left alone. And then after an assessment procedure where they are assessed whether they are able to do this procedure, they are left alone in their hospital, so they go back to their hospital and they start doing this procedure. But they're still supervised in a way, because they still have the possibility to go back to their original trainer, or they can ask for help if they need to. This whole process takes about 1 to 2 years for each trainee. And obviously all these trainers, they have taken on several trainees. Portsmouth was one of the biggest centres, was actually the biggest centre that they had most trainees. I don't know how many I've done it yet, but 21, so they trained 21 surgeons in the last 4 or 5 years. This whole process was audited, or had kind of quality control. What we tried to do is to establish methods to measure the progress of the trainees. We didn't want to use clinical data as such, because as I showed you before, this is ethically not very clever to do that. So what we did is basically creating forms that had to be filled in after each case, which was basically a breakdown of the procedure into different steps, and each step had then to be rated by the trainer. And I don't want to go too much into the details of that, but basically what we could do for the first time is to create a learning curve, or to describe a learning curve for this type of surgery without using clinical data. And we could show that it takes probably about, on average, somewhere between 20 and 30 procedures, supervised procedures, to get to the top of the learning curve. And it also enabled us to see that not every trainee is the same. Some progress much quicker than others, and that we can't just tell or give you a number where you can say you need to do this number of cases before you can do the surgery yourself. And part of that was also this signing off assessment where by the end of the training we were looking again with a special form at how the trainee is performing before we left them alone. What we basically could do is identify those who are competent by using this type of assessment, and we could also identify those who are not ready yet and who needed more training. Again, I don't want to go into the details of this because this is all a bit boring, but the gist of it was that we could show that if you train people properly, you can reduce the learning curve from more than 100 cases to probably about 20 to 40 procedures. And the second, maybe more important thing was that we could show that if you train people properly, you don't have an accumulation of negative outcomes during the learning. So basically the patients always got the best possible treatment throughout the training of these surgeons. And of course we were looking at clinical results as well. We were looking at clinical results during that supervised period. We were also looking at clinical results when they were left alone. And again, I don't want to go and show you all these numbers in detail, but basically what we could show that the results remained stable. So whether they were in training or after training, the clinical outcomes, they were always the same. So I just show you this one because these are the outcomes of the trainees when they were left alone. So they had a certain patient selection, which was actually wanted. What I said to you yesterday, and what Amjad said earlier as well, is you should select your patients when you start. So they did that clearly. They used, you see, they had patients with kind of lower ASA, so low comorbidities. They didn't do like T4 cancers, and most of them had an average or a low BMI. And when we look at the outcomes, post-operative outcomes, you can see that, so the blue bars, these are the outcomes during training, and the green bars are the outcomes after training. And you can see that they all remain the same. The only thing that changes is that they have slightly more conversions when they are left alone than in training, which is understandable. Now, one more thing about this program, because people said, so how can you finance this? You know, this is a lot of money, and it was a lot of money. They paid somewhere around 12 to 15 million pounds, which is probably about 15 to 20 million dollars for this program. So we were interested, is it actually worth doing this? And we were comparing what is the potential gain, how much can we actually gain by training people or reducing costs by reducing complications and reducing hospital stay, and how much do we have to pay for it? And what you can see is that the program, with saving complications and saving length of hospital stay, saved probably around 15 million pounds or 16 million pounds. So as an effect, the government probably gained money rather than they had to spend it. So what to do in Russia? And that's a very big question, and I think many people before me failed to answer this question. I was thinking first, what is the difference between the UK and Russia? Can the same thing be reproduced in Russia? So I entered British into the Google search machine, and this is what's coming out. You can see the British, they are obsessed with their flag, and they have a bit of history, mostly wars, and there's a big world map with the British Empire. So I wondered what happened when I enter Russian, and this is what happens when you enter Russian. So I thought you're actually living in a quite interesting country. But there are obviously some differences between the two countries. So can you reproduce the type of English national training program in Russia? And I think the short answer is no. And there are some reasons for it. I think one is, look at the sheer size of your country. I think part of the secret of the English national program was that people were very close. It was very easy to travel around. The distances are not that big. But in your country, I think this would be very difficult to get trainees from one point to the next. The other big difference is there is a thing called the national health system in the UK. The healthcare system in England is very organized from the top. So the allocation of money and everything is very centralized. And not only the money, but also how things should be done. So the government can say, we need to train these surgeons, and then they have to do it. And I think, although I don't really know the details of the Russian healthcare system, it is probably not exactly like this. But I think there are opportunities, and I think these are your opportunities. This was when a group of Russian surgeons, including Alexei, came to visit us in Portland. And these people, they were very interested, and they came from different parts of the country. And obviously today as well, and yesterday, there are people from all over the country. And I think you are the ones who can actually drive this. But what you have to do, I think, is to go through certain steps before it can spread out to the whole country. And I think the first step is that centers of clinical excellence have to be established within Russia. where you just decide amongst yourself who is going to be a center. They have to be spread out geographically, and you have to collaborate very strongly between the centers. You can't do this on your own. The centers, or the leaders of these centers, have to become very strong clinical and also educational leaders. So it's not just about being a good surgeon. Of course you have to become a very good laparoscopic surgeon, but it's also becoming a good trainer, a good educator. And I think these centers, they have to become dedicated laparoscopic units, where you actually say that you are doing laparoscopic surgery as a primary aim. And I think then you have to start spreading out. And you can do this by offering courses, by organizing events like these 2 days. And you have to consolidate links to the industry. I think this is all happening. I'm not telling you anything new. What I'm trying to say is that these are things that it's a different approach than what we did in England, because it has to come from yourself rather than from the top. And the final stage would be to become educational centers of excellence. So I think these centers, once they are established properly, they have to offer whole packages where people can come to your center and can be trained, and they know that they can come there, and they know that when they come out of there, then they will be fine. And I think the potential of all this is that you have a big impact. Because when you look at what happened in our country since 2006, it was a big difference. So the national average of laparoscopic surgery in colorectal resections has reached 45% now. So it has increased, it's basically tenfold of what it used to be only about 7 years ago. And I'm not saying that this is all because of the national training program, but it had definitely a big impact. And I think if you organize yourself in a similar way, you could have a similar impact here as well.